going to cover, I think, a lot of helpful information today, and I'm really excited about this planning method. So the idea is to make the planning as simple for your optimization algorithm as possible and just not have any conflicting arguments. And so if you follow these simple rules, you should be able to get a almost perfect plan in a first try. So that's where we're going today. So today we're teaching the Shulman method of treatment planning. I'd like to say thank you, as always, to Claire Dempsey and Ben Lee for helping. They are always working behind the scenes. Ben is sort of up all hours. So lots of thanks to them for constantly helping to make everything better. So I don't really have much of a PowerPoint presentation. I'm really just going to be sharing my screen and going over the document that we've created, as well as tutorials in my Eclipse treatment planning system. And so it's important to know that these are vendor non-specific. So the same principles can be used on any treatment planning system. I'll be demonstrating in Eclipse because that's what I have, but we can follow these same principles and get perfect plans on any treatment planning system. At the end of this presentation, there's an appendix on choosing beam angles. Choosing your beams is always important. I'm not going to talk a lot about this because I think it's covered in other presentations, but it will be there for your reference. And maybe if we have time, we can quickly go over those as sort of a reminder. But mostly I'll be talking about how do you create contours for optimization and how do you actually optimize once you have those contours. So I'm just going to do a sharing my screen from here forward, where I'll share the document and I'll share my treatment planning screen. Okay, can you all see my share? You can still see, okay, perfect. So first we've got this really nice treatment planning document. Again, Ben and Claire helped a lot, and Ben really made it really nice with some embedded other instructions. So we'll go over this at the same time that we go over our live demonstrations in the treatment planning system. So I'll sort of be swapping back and forth between this document and my Eclipse system. And so we're not going to create too many contours. That's an important thing. We're not going to create all kinds of organ at risk contours. We're not going to create a bunch of helping structures. If you start planning and by the time you get to the end of your plan and you're having to create like a Z hot structure and a Z cold structure and trying to fill in gaps here, and a Z spillage structure and trying to remove high dose that spilled outside the PTV, you can think you probably need to go back and assess your original contours and how you're optimizing. So hopefully after today, you'll have a little bit better idea of that and you won't need to create those structures. So we're only going to have to create the structures that are in this document. If you think that you have to create something else, go back to the document, go back to this tutorial and refine that approach. So we got ZPTVs. These will help protect any critical max dose organs at risk. We're going to be subtracting out max organs at risk. These are things like optics, brainstem, spinal cord, things that you will sacrifice your PTV coverage in order to protect. So we'll actually remove aspects of our PTV from these organs at risk, plus a margin, which we'll get to. We've got a ZOAR in PTV. So these we'll get to. It helps protect any critical mean organs at risk. So this might be something like a parotid. So sometimes we might be planning a head and neck, and the doctor will say, okay, the disease is on the right side, but I want to spare the parotid, the mean parotid dose to say 24 gray. So it's a little bit difficult to know exactly how to shape your PTV to get 24 gray for your mean dose. And your doctor, he or she might say, I'm willing to sacrifice my PTV coverage in order to ensure that at least the left parotid is spared to mean of 24 gray. So that's what this structure will help with. ZPTV underscore opti underscore max. So this will be limiting our hotspots within our PTVs. So when we have multiple PTVs, say a PTV 50 and a PTV 70, well, we want to ensure that we've got relatively low amounts of 5% in both PTVs. So the best way to do that is a separation of the two PTVs. We got the ZPTV Opti Rind. So that'll be sort of the outer edges of each PTV. Again, this is really helpful for as you're optimizing dose fall off at the edge of a PTV, or you're optimizing really sharp dose in an organ at risk, like a brainstem or a parotid, it's going to be pushing the limits at the edge of the contour. So we make this Rind PTV to help with that, knowing that that will be a difficult part for the optimizer. A similar difficult thing for some optimizers is the corners, ZPTV opti corners. So this again is in PTVs. You can think about nodal chains, so head and neck, where you got those middle dose nodal chains that sort of point out, or pelvic nodal chains, they're really sharp, long nodal chains. Well, some optimizers will struggle to get dose in those outer parts of those nodal chains. And so we foresee that difficulty with the optimizer. So we create these little structures just to help the optimizer out a little bit in those areas that we know will be difficult. We create 2 sets of rings, which we'll get to. Eclipse users only have a normal tissue objective. There might be something similar with your own planning system. We'll teach the principles how to use it and how to know if you can use it. And then other planning structures, we won't really get into much, which have been covered, talking about PRVs, artifacts, or avoidance structures, that sort of thing. And then we get into the optimization process. And I'll briefly touch about this. So we've briefly talked about these different PTV structures where we're knowing ahead of time where the optimizer might struggle in terms of areas like the rind or the sort of corners of nodal chains. We've talked about separating out contours. So separation of PTV contours is important because if you think about having an overlap of, again, I'll go to PTV 50 and PTV 70. I'll show this on the dose optimizer shortly, but if you don't separate the contours and you allow a hot spot in your PTV 50 in order to get PTV 70, since they're close to each other, well, it's tough for the optimizer to know where to put the hot spot. I'll show you on the DVH, it will become more clear. And similarly for organs at risk in terms of your optimization, keep this in mind. I'll show you on the optimizer shortly, but we want a methodical approach to optimization. So the way generally the way an optimizer works is it starts out with coarse MLC positions, whether it's IMRT or VMAT, the concept is the same, very coarse positions. And as you begin to optimize more and the optimizer progresses further in the process towards the final step in any optimizer, what happens is all the MLC shapes are basically set. And so if you're avoiding a parotid, well, most of your MLCs are closed along this portion of an arc where it's sort of going through the parotid, blocking that dose to get a steep dose fall off of the parotid. So if all of a sudden at the end of your optimization, you decide, actually, I want to push dose in there. Well, you're going to push dose in through the parotid, and it's going to give a big hot spot in the PTV, and you've messed up your whole process. You're no longer at a local minimum, and optimizing at that point does not work well. So you want coarse optimization at the beginning. Coarse optimization would be avoidance of these critical structures. You want a big coarse MLC closing along your brainstem. You want a big coarse MLC closing around your parotids. And when you start getting further in your optimization, this would be something like step 3 in Eclipse or step 2 in Monaco. All you want to do is everything looks pretty good, but not quite perfect. So you just want to fine tune your MLC motions. Just tiny little bits of motion in your MLCs, and you can go from little bits of hot spot to uniform dose in your PTV. You can go from almost covered to perfectly covered in your PTV. You can go from too much of a hot spot in your brainstem to just sparing the brainstem, just with these minor adjustments. So you go from coarse adjustment at the beginning to fine adjustment at the end. If you find that you have to do some sort of coarse adjustment, you've forgotten something near the end of your optimization, just start over, go back to the beginning. Otherwise, the optimizer won't work in your favor. That's how an optimizer works. And so there are a couple rules of thumb. Everything's laid out in this document. I'll go over these and then we'll start going to the treatment planning system. So the maximum dose fall off confined to a small volume. So this is something like the dose fall off around a small organ at risk. So around a parotid, around a spinal cord, around optics. These are small volumes, so you can have really sharp dose fall off. In most planning systems, it's about 10% per millimeter. It can be a little bit higher. If you got a more advanced algorithm or a later version, it could do a little bit better, but our rule of thumb is pretty much 10% per millimeter around these small organs at risk. If you're talking about around an entire PTV or around a big organ, so a big organ would be something like large bowel. So you get this large bowel that goes around most of, say, 30% of the circumference of a PTV. That would be considered a large organ and less steep of a dose fall off. So in these, or around an entire PTV, if you're talking about uniform dose fall off, our rule of thumb is 3 to 5% per millimeter. Typically 5% close by, and as the dose gets further away, it's not able to fall off as sharply. So further away, it's more like 3 millimeters, 3% per millimeter. So for example, a ring that's 3 millimeters away from a PTV, where that's the start of a ring, should have a max dose of about 85% of the prescription dose. That's 5% per 3 millimeters, 15% dose fall off for a ring starting at 3 millimeters away. But when you have a ring that's 13 millimeters away, now that's a little bit further. The dose fall off won't be quite as sharp. What we found is that you've got about 65% of the prescription volume. So if you do the math, 100 minus 65, that's the dose fall off. Divided by 13, you're at about 3% per millimeter. Okay, at a little bit further away. So these are sorts of our rules of thumb that you'll always need to think about when you're doing these contour creations. There's a nice little link here. So Ben has embedded some of our PowerPoint presentations from other presenters here, and he's got some other helpful documents embedded inside. Okay, so the big thing to remember are these rules of thumb and these ideas of how we're contouring. And now we will get into the actual contouring. Okay, so we want to create ZPTVs. So I'm going to show you a couple examples on a couple of different plans. It's tough to go over too much because we only have a limited amount of time, but I think you'll get the idea. Also, we've got some recorded RCC demonstrations start to finish of how to do treatment plans on head and neck and on pelvis. And we're going to do some other live demonstrations in upcoming tutorials, which are going to be really cool. So I'll be giving one, I think in 2 weeks, and some of my colleagues will also be giving some.
Thank you, Adam. I'm getting some messages that seems like your mic is not as, like your voice isn't as clear as it could be.
Okay.
Maybe you could have it a little closer,
Let me try
if you don't mind. And I hope that helps.
Can you hear me better now?
Yeah, I can. I'm just asking because like about 3 people have messaged me. I don't think it's a big issue, but yeah, go ahead. And if I hear back from the folks, I'll let you know again. But thank you.
Yeah, I will try to talk loudly. I don't see any other settings that I can do for my microphone. Yeah. Sorry, everybody.
No, this is great. I think this is much better now. The microphone that is closer.
Okay.
Thank you.
Yep. Now you guys just get to look at my face really closely. Sorry. Okay, so we're gonna follow this guideline and we'll start looking at ZPTVs. So again, these are PTVs where we're subtracting out max organs at risk that have to be spared. So things like spinal cord, brainstem, optics. I'll show you a couple things in here just that it's clear, and I'll show you a little document that Ben embedded. We've also got a ZOAR in PTV. So again, this is for the mean doses. And if you just click on this, so all these are links that you can just open, which is really nice. So I'll bring it over here. Ben drew some nice little pictures. So here's your PTV, perfectly drawn on this person. And here is a max dose constraint OAR. So this would be like a brainstem. We can't sacrifice brainstem. We have to sacrifice PTV. Here's a mean dose. We want to cover the PTV, but we want to improve the mean dose of this organ at risk as much as possible. So the idea of a ZPTV is this. We're going to include this mean or OAR, right? That's okay. We're allowed to give dose to the organ at risk. We just want to improve the sparing of it on this side. But the maximum, we cannot overdose a brainstem, right? That would not be good for the patient. So for the ZPTV, we would subtract the brainstem plus a margin. Again, the margin is dictated by that dose fall off. which we're going to get to shortly, to see exactly how much that margin should be. This ZOAR in PTV. So now, again, let's say we've gotten our mean dose as much as possible the way it is, but it's still not covering that mean dose of 24 gray that the doctor wanted. Well, if we know this ahead of time that we might want a little bit of room to make improvements, then we create these structures. So in the end, if I zoom up, here's a red structure, which includes all of the organ at risk overlap and the PTV. Then the ZOAR2 in PTV is this yellow one, which is everything except for this 2 millimeter expansion. The ZOAR3 is this blue one, which is everything except for now 4 millimeters expansion. And so what this allows you to do, as you can envision going forward, is that let's say you started optimizing on your ZPTV in purple and this red one, and you just weren't able to get your mean dose. So then all you do in the optimizer is remove this one, this red one, and then you would optimize on the purple, the ZPTV, and the yellow, the ZOAR2. So now we're saying we can reduce dose in this little area. So if we say that we can reduce dose in this little 2 millimeter area, now we can improve this parotid dose even further. If we're still not able to reach the mean dose, we remove the yellow one, we add the blue. So now we're able to sacrifice dose in this whole area 4 millimeters in. That's the idea of these two structures. And so in terms of dose fall off for these maximum organs at risk, again, we want percent fall off needed divided by percent fall off per millimeter. So if we need a 20% dose fall off, and we're at one of these small critical structures, so a small critical structure, we've said 10% per millimeter. So 20% divided by 10% per millimeter, that says you need 2 millimeters in order to get that 20% dose fall off. Okay, so the equation is here, PTV dose minus OAR dose divided by PTV dose divided by X, where X is the percent fall off per millimeter, dose fall off per millimeter. And this X is for you to decide based on our rules of thumb, 10% for small, 5% for bigger areas. Okay, so we just use this math. So for example, for an organ at rest, say a brainstem PRV that we want to limit to 54 gray, and our PTV is going to 70 gray, and in order to cover the maximum amount of your PTV, but spare completely 54 gray to the brainstem, we'd follow this equation. You need 3.3 millimeters. And this is really important for optimizing, because if you optimize and you don't do any of these subtractions, and you want to know, and you try to tell your optimizer, okay, spare the brainstem, but cover as much of PTV as possible. Well, how much PTV is good? When that shoulder drops, you know the shoulder is going to drop because you're trying to spare brainstem, but how much do you allow the shoulder to drop before you don't know? But if you know the maximum dose fall it can have, now you can 100% cover the PTV 3 millimeters away from the brainstem, and you can 100% spare the brainstem. Now you've guaranteed that you can get as good of organ at risk sparing as any other planner, and you can get as good or better than any other planner in the world at your PTV coverage. You've maximized those two. So it's really important to separate these contours. So now when you optimize, you're always looking at a sharp PTV, and that's important with maximum dose fall. Okay, so let's finally go to the treatment planning system. And let's look at a couple of these. So this is a challenging case. So I'll spend a little bit of time on this while also looking at my clock. The clock goes quickly. So we won't go too much into these contours, but the idea is that we've got a PTV 60 in this sort of light green, a PTV 45 in red. This is a sort of weird contoured spinal cord and spinal canal just because of the patient has this really severe disease and can't really see spinal cord or cauda equina anywhere. So this is how doctor contoured just to be extra safe. Okay, so we just want to talk about how do we contour these structures. I'll pull up an image. This is what the doctor wanted. So the doctor wants left kidney spared as much as possible. This would be super easy, but the tricky ones are small bowel PRV, large bowel PRV, spinal cord less than 40 gray, and cauda equina less than 48 gray. Okay, we're going to use our math, our rules of thumb, and we're going to create contours so that we can get perfect coverage of this plan. Okay, so we'll start one at a time. So these are the doctor's original contours. So we'll start with PTV 60. And so we'll look at one organ at risk at a time, and we'll just keep subtracting. Okay, so in this case, the large bowel PRV is a hard constraint. This patient has extensive disease. It's palliation. We don't want to cause extra problems by destroying the bowel as we're trying to palliate the patient. In this case, the large bowel is also a hard constraint. Okay, so we want to subtract from the PTV. All right, so that is the hard constraint for the large bowel is 50 gray. So 50 gray divided by 60 gray is 83%. So 1 minus 0.833. So we need times 100 to get in percent. We need a 16.7% dose fall off between 60 gray and 50 gray. That's all I did in the math. I followed that equation on the sheet. The dose fall off between 60 gray and 50 gray is 16.7% when we follow the equation. Now, this is a large OAR. This is not a small little structure that I can have maximum dose fall off. This dose fall off is going to be smaller. So let's say it's 5% per millimeter. So divided by 5% per millimeter, this says that we need 3.3 millimeters at 5% per millimeter dose fall off for a large structure to go from 60 gray to 50 gray. Well, here, this is not 3.5 millimeters, right? And so if I optimize like this, again, my shoulder is going to fall in order to, I know my shoulder has to fall in order to spare my bowel, but it's a large volume. How much do I let my shoulder fall? Do I let it fall this much? Do I let it fall this much? You have no idea. What's going to end up happening is you get cold spots all through the PTV. And you're going to get a really wide gap at your margin here. And so if we can maximize that dose fall off by separation of PTVs, what we'll do is we'll get full coverage of PTV, full sparing here. So what we're going to do, we're going to create a structure, and I can just, well, I've got a temporary structure right now. So I've got a temporary structure here. So I'm just going to subtract. I'll do a crop structure, different ways of doing it on your planning system. And I'll take my PTV 60, remove parts extending inside of my, my PRV for my large bowel. And I'm going to say 4 millimeters. So it said 3.5 millimeters. I know I'm not super worried about it. I want a little extra room with this big thing. I'll just say 4 millimeters. And we will call this a new structure. This will be a PTV. And sorry, we're not there yet. I keep trying to go ahead. So we'll call this our temp. So I'll say yes. So here's the new temp. And so we would now do a Boolean operator. Or sorry, I'll do it quicker. Different ways of doing it. Ultimately, you just want to subtract them. So I can start doing this. I'll call this my PTV. And we'll call this Z, following the instructions from our TG report and what Claire presented last week and what's on our document. We'll call this Z PTV. Oh, it's just Z PTV 60. Okay. And so now we got a new Z PTV 60, which is 4 millimeters away from our large bowel PRV. All right, we'll do the same with our small bowel. So small bowel PRV was limited to 40 gray. So the same math, small bowel PRV, it's up here. It's a large structure. Here's the yellow. Again, 5% per millimeter for large structure. So 40 gray is our limit divided by 60. So 1 minus 0.666 times 100. So we need a 33% dose fall off. Now, just to remind you, we could say divided by 5 and say it needs about 7 millimeters. But remember the rules of thumb. So we've got 5% per millimeter for large structures up close, 3% per millimeter when it gets a little bit further away. If you remember our discussion of our ring was 65% at 1.3 centimeters. So let's see, if you look at the 40 divided by 60, that's about 65%. That's similar to our second ring that's 1.3 millimeters away. Okay, so a ring is for all the way around the PTV. So there's a little bit of margin. We could call it anywhere between 3 and 5% fall off for 35%. So we need 35% fall off. Divided by 5 is 7. 35% fall off divided by 3 is 12 millimeters. So we can have it somewhere in between there, right? It's not all the way around, so it probably doesn't need the 3% per millimeter. It's not small, it can't do 5% per millimeter. It's a little bit further dose fall off. You can do something in between 7 and 12. Let's just pick 1 cm. Okay, it seems pretty reasonable. So we would do a 1 cm dose fall off. It's in between the 3 and 5% per millimeter because the dose fall off has to be a little bit more. So it means it has to go a little bit further away. The dose fall off will be a little bit less than the 5% per millimeter. So we'll have now our Z PTV 60, and we'll have it removing our small bowel PRV at 1 centimeter away, and we'll keep it our Z PTV 60. Okay, so here it is now. Now we're 1 cm away from our small bowel PRV. We're 4 millimeters away from our large bowel PRV. And now we need to worry about spinal cord and cauda equina. Now, if you remember from our dose objectives, spinal cord, max dose at 40 gray. So we'll come back here. We just did 40 gray. Remember that was 35% dose fall off. 40 divided by 60, 1 minus that times 100. I miss it. You get the point. It's 33. And but now it's a small organ at risk. So small means 10% per millimeter. So divided by 10, 3.3. So we should, in 3.3 millimeters, go from 60 gray to 40 gray for our spinal cord. I think I'm not at our spine. Here's my spinal cord. So we need 3.5 millimeters. So you can either do 3 or 4. This is a complex planning because it's so large, they're tough to plan. And it's palliation, so I'm gonna opt for 4 millimeters instead of 3 millimeters. Either one is viable. I think 3 millimeters might be a little tougher because that's over 10% per millimeter. If you have the ability to do 3.5, you can. Most planning systems have whole numbers of millimeters. So I'll round up slightly. I'll do a 4 millimeter subtraction. So now I'll go inside of my spinal cord. There's no PRV on this particular case, just because, again, the particular anatomy and inability to distinguish spinal cord in this extensive disease. So I'll do a 4 millimeter margin, and there we go. Just subtracts out a little bit right there in some other areas you can see. And the same thing with the cauda equina, which is 48 gray. And so we'll do 48 divided by 60. That's 1 minus 0.8 times 100 to get a percent. 20% fall off from 60 gray to 48 gray. And divided by 10% per millimeter leaves us with 2 millimeters fall off to our cauda equina. So it goes to our cauda equina and 2 millimeters. And there we go. So now we're done with everything that we need for our spinal cord, for our PTV 60. We would repeat the same process for the PTV 45, noting that if you look at here, PTV 45, the large bowel is okay. You don't need to do any subtractions from large bowel. We're allowed more dose in large bowel. So you just do the same math for the same subtractions. For the sake of time, I'm not going to continue doing this for PTV 45, and we'll move on to another case so I can start looking at some of the objectives. But this is the idea of of following these examples. I will quickly touch on, you're going to have to, sorry, I apologize. I made these structures a few days ago. We changed the nomenclature. So please follow the nomenclature in this document. Right, we've got these, this is TG, this is the TG nomenclature. I've got some that are labeled a little bit wrong. So try to ignore the long naming system and just follow the principles that I'm teaching today. So apologies for that, but I will show you this case where I've also done a couple of these mean dose, these right here, the ZOAR in PTV. That's for optimizing those OARs. Okay, so we'll quickly look at that. I'm not going to do the subtractions just for the sake of time. The instructions are there, different planning systems. There are lots of different ways that you can get to these contours. Just make sure that your contours look like this. So zoom up. Here's my PTV 52. Here's my parotid. I might have a tough time getting a mean dose of 24. My doctor has said I can sacrifice PTV in order to get that mean dose. So I create these helping structures. Again, please forget the names that I have here.
Okay. Yeah, thank you so much, Adam. This is great. I just want to remind everyone that I'm gonna resend the link for these instructions, just making sure that everybody's following. But this is great. Thank you. And we do have one question. It just came through, if you don't mind, Adam. Evaluation of which PTV do you use for evaluation?
Great question. So, and this will be in your instructions document as well. There are two different structures you can use, honestly. I evaluate on my PTV, my ZPTV Opti Max. Some people will just subtract out the PTVs without that margin. That doesn't matter. You're going to have high dose in that area. It's going to be covered. So I use my ZPTV Opti Max for analysis. That's a really good question. If you analyze your coverage of a large PTV 54 margin, I'm sorry, a large PTV 54 PTV, large volume PTV 54, and you include in that analysis like PTV 66 and a PTV 69, what's going to water down your DBH. So your shoulder might look good, including all those other high dose PTVs. But if you look at only the PTV 54, subtracting out your other high dose ones, maybe that shoulder drops and you didn't quite get your coverage. So yes, you want to analyze on your Z PTV Opti Max. Good question. And so quickly here, we'll look at the original PTV 52 is this blue. So I ended up with a maximum, which is this red. We'll take off the blue, which is a little bit inside of the parotid. It allows for the possibility to spare more. You don't have to, but the possibility to spare more, plus this little other structure. So these two combined equal your PTV, your original PTV. So if I optimize on this and this together, lower objectives, I'm going to get my full coverage of PTV. No issues there. But the idea of having these little separate volumes is that I can slowly remove them during the optimization process without having to go back and recontour and without having to have conflicting arguments, which is going to make your dose objectives look bad. And so I got two of those in there. Again, please ignore the names, all the names on the instructions document. So as I'm optimizing, I might remove this one and then optimize on this one instead. 2 millimeters in, it lets my dose drop in even further. If I still can't cover it, then I'll remove that one too. And then I'm just optimizing on this. So you can slowly cut away on your PTV just around these organs at risk in order to get coverage. Okay, that's your ZOAR in PTV. It's really nice. All of these are really great for scripting. So if you follow the TG nomenclature, and if you follow our guidelines, and you've got someone that's scripting, or hopefully soon, RCC will provide scripts for Eclipse and Monaco and other planning systems. Following the Shulman method, you'll be able to do this planning even quicker. Your max structures, so we want to create Z PTV Opti Max. So this is between PTVs of higher dose levels. The same concept, it's PTVs surrounded by other PTVs. So we go by 5% per millimeters. We want to subtract those out. So if we look at this case, for the sake of time, I'll just quickly show you. So we've got my original PTV in blue. This is a PTV 60. This red one is a PTV 63. And if I have them overlap, that's not good. If I just do a subtraction, well, I'm going to have a lot of dose fall off going from 63 to 52. Where is that? If I don't put in a structure, I could get hotspots here or here. My shoulder doesn't know where it is. So subtract it out so we can limit 5% or 8% in my actual PTV of 52. And we won't worry about that sharp increase in dose between 52 to 63. And so again, you would just do the 52 divided by 63. We're looking at the dose fall off for the margin for my max structure of PTVs. So it's about 18% fall off. So 1 times 100, so that's 18%, 17.5%. Divided by 5% per millimeter is completely surrounding the PTV. 3.5 millimeter margin, we'll just call it 4. So I should have a 4 millimeter margin here if I measure it. Let's see if my math was right. Well, depending on where I am, it's about 4 millimeters margin. Okay, and that allows me to get complete coverage of this and to limit my hotspots here without any conflicting arguments. And the same thing for PTV 60, I would do that same math. And I've got a little margin between 60 and my Z PTV Opti 54. Okay, so that's the idea of these maximum structures.
Great. Thank you so much, Adam.
Yep.
Somebody is asking a question about who draws the organs at risks. And since you are drawing these new PTV structures, do you have the physicians to check them again?
Yep, good question. So to the first question, who draws the organs at risk? That would depend on your clinic. And so typically this comes down to expertise and workload. So lots of centers, I think the dosimetrists end up contouring all the organs at risk and the doctors will review them. But I've seen centers where the doctors contour everything. You don't have to worry about anything. It's a luxury as a physicist if you get that. Sometimes the physicist has to contour. We do have planning sessions on contouring organs at risk. There are atlases. You can also ask to join some of the RCC contouring sessions. There's information out there on how to contour, but typically dosimetrists or physicists will have to contour organs at risk. And then these optimization structures on your PTVs, you do not need to show your doctor. This is what you can cover, so they're there to help you. And your doctors will be forever grateful when you show them your first few plans when you optimize in this way, and you've given them coverage and organ at risk sparing that they didn't think was possible. They're going to think you pulled it out of the textbook. So they'll be very happy. You won't have to show them. They'll just be really happy with the coverage that you're able to get. So I'll show you these. Oh, go ahead.
Sorry. So my concern is because the dosimetrists draw the OARs and the physicians define the PTVs. So if we keep changing the PTVs based on the OARs that dosimetrists defined it, I feel like these have some conflict, you know? We just keep changing the PTVs while the doctor thinks that here is the area of the PTV that we need to treat.
Yep, really good question. Thank you for that. This will be helpful for everyone. So it's important that the contours are correct in the high dose areas. So in this case that I just planned, for example, or this one that we were just talking about, yeah, if the parotid is not correct, then what's the point? I'm trying to spare parotid. The doctor should look at organs at risk. The doctor should look at closely, and if he or she doesn't, it should be a discussion within your department to try and implement this, because you are correct. The organs at risk close to your PTVs are almost as important as the PTVs themselves. And so what most institutions do, and if you don't, you should try to implement it, that the physicists or dosimetrists will contour the organs at risk, give these to the physician. The physician will contour the target volumes, and any organs at risk that are close to that he or she is concerned of, he or she has to review those contours and correct them if necessary. And so again, like this other patient, yeah, I did all of this subtraction. Well, if the doctor only wanted the spinal cord like way back here, then I wouldn't have needed to do any subtraction. And now I've just undercovered what the doctor wanted. So really good question. So the doctor, before I ever start subtracting these PTVs, this is a critical organ right next to, or even in some cases inside of the PTV. the doctor has to look at this and ensure that it's correct. That's a very good question. That's the only way that this process works, but it's how the process should work in your department. Any critical structure close to an organ at risk has to be reviewed by the doctor, and the doctor has to give you constraints on those organs at risk so that you know. I need to know, in this case, the bowel has to be spared completely with max dose. It's not a mean dose. I'm not just going to try and limit it. This is what the doctor explicitly wants in the doctor's prescription. So really good question. And I'll show the last two PTV structures that we make. We make this Rind structure and we make a corner structure. And so a Rind structure, I'll show it on this case. Again, you're going to have to ignore the nomenclature. Apologies. So without being too confusing, I'll put on my PTV 60. This is the one that I've already subtracted all my organs at risk from. And then I'll want to put on that Rind structure. Again, don't look at the name, just look at the contour itself. So this is a 5 millimeter rind around the inner edge of the PTV. Knowing that we want sharp dose fall off here, we want sharp dose fall off here. The optimizer is going to struggle more at the edges than it is anywhere else. So we're going to anticipate that and put this Rind structure. The corner structure, and I'm just going to very briefly show this because we need to get to the optimizer. The corner structure would be something like this, head and neck, where you've got these nodal chains that come down. Well, the optimizer, some optimizers will struggle more than others, but we can anticipate this area right here, if you can see my mouse, is going to be a little bit more difficult for the optimizer than this area. This is going to be easy for the optimizers. Right near high dose, it's a big chunk of PTV. It's not going to have a hard time covering here. But trying to curve dose around this area, it's going to be a little harder for the optimizer. You can put in these little corners right here and here, go slice by slice. Easiest way is copy and paste the PTV, erase away, just leave these little corners. Help the optimizer out where you know it will be more difficult. Okay.
Adam, there is a question from Anissa. She's asking if our ZPTV crops the GTV, what should we do?
Good question.
We include that GTV into our ZPTV. Thank you.
Yep, very good question. So again, this discussion has to be had with the doctor before you ever start. And so if the doctor gives me these constraints and says, I have to have large bowel PRV less than 50 gray, I have to have this, I have to have this, then I will make those contours. These contours that I have on, sorry, I'm on the wrong patient. These contours that I have on this patient, by following what the doctor has dictated, this is exactly what's possible. So I can't get any more PTV coverage than this. This is as much as I can get in order to spare those organs at risk. Now, if I put on a CTV or a GTV and it's not covering, I can tell the doctor ahead of time. I can go to the doctor and say, okay, this is what you told me that you have to have. I can tell you before I ever even start planning, I can achieve exactly this coverage, but I can't do better. I've maximized my dose per fall. This is only what I can achieve. So if I'm missing CTV or I'm missing GTV, then you'll have to tell the doctor, this is what I can get. I'm going to miss some CTV. I'm going to miss some GTV. Do you want to sacrifice any of these organs at risk more than you are now to allow me to cover that CTV or GTV? So really good question. You should have explicit directions from the doctor, and with these strict guidelines and percent fall off per millimeter, I can show the doctor, this is what I can cover. I guarantee you, you cannot cover more PTV than this and spare these organs at risk. And so I can tell the doctor before I ever start planning, this is what you can get. So again, a really good question in communication with your doctor. So I'm going to quickly go to a little bit of optimization just to sort of show you some of the ideas of the optimizing process. This is the idea of the contour. So get your contours perfect. If your contours are perfect, the optimization should be really easy. If you find that you're struggling with the optimization, go back and reassess your contours. Our rules work. It never takes me more than one time to do a plan to get a perfect plan. And it usually takes start to finish contours and planning maybe an hour and a half. So we'll open this up. I'll go to my optimization. And again, quickly, just because time is flying in our optimization, we've got our rings. the 85% and the 65%. Talk a little bit about normal tissue objective in eclipse. If you don't have it in eclipse, you might have something similar. Other planning structures as needed. So basically, again, to reiterate, you start with gross C adjustments, and then as you progress further into local minima, you want to lock your organs at risk in place, and then fine tune with MLCs to get PTV coverage. And here is a good, explicit instructions on where to start all your optimization. So on all of your PTVs, we'll start with 100% of PTV receives 101% of prescription dose. You just go a little bit higher in order to get the coverage. Weighting of 200. You can put some dummy ones on of 98% of your PTV. So here's to answer that question, we analyze on the ZPTV Opti Max. You can put a dummy objective just so you can visualize 98% of receives 100% of prescription dose with a weighting of 0. This does not impact the optimizer at all. If you have a weighting of 0, it just shows you a little point so you know where you're trying to optimize if you're getting close to what you want to achieve. Upper limits, we put 0% of your Opti Max at 105% of prescription dose, weighting of 200. You can put a dummy one at 101% of prescription dose for Eclipse users only. This dummy one at 0% weighting is just because in Eclipse, the starting dose in Eclipse NTO means percent of lowest upper objective. So an upper objective is a max objective. In this case, if we put a maximum objective at the same 101% that we're doing for our minimum objective, that means that 100% starting dose fall off is at prescription and comes down. Okay, that's all that is. That's only for Eclipse users. And then your rings, just like we said before, your first ring is 3 millimeters away from your PTV. Your second ring is 1.3 millimeters away from your PTV at 85% and 65%. One thing I didn't talk about the rings, if you've got a head and neck case with, here are two different, this is, I don't even know what the prescription is. This is 60 gray. This is 54 gray. So the easiest way to do this is to do a ring for your lower PTV, 54 gray. And let's say it's 3 millimeters away from your PTV. Then you'd have to subtract maybe a little bit more from that ring to have it a little bit further away from your PTV 60. So for example, I've made a ring 3 millimeters all the way around both my PTVs. So that would be 85%. That's going to be our maximum dose objective times 54 gray. That's the PTV is 3 millimeters away from. That means it's 45 gray. Well, let's see what percentage dose fall we need from our PTV 60. So again, the same rules of thumb, divided by 60, 1 minus 0.765. Times 100, so we need 23% fall off. So again, if we use our rule of thumb, 5% per millimeter divided by 5, you'd need about 5 millimeters dose fall off. So if I put a ring all the way around both of these, show you real quickly, let's see, I'll just make a temporary structure, just show you Boolean PTV 54 and PTV 66, PTV 60. So now I've got this structure. It's both my PTVs. So let's make a new structure. We'll call it Z. Sorry, let me look at this. Z PTV Opti Ring 1. Z PTV Opti Ring 1. And so I'll do a expansion of my temp. He said 3 millimeters away from ring 1. So I'll call this my new temp. So now my temp is 3 millimeters away from both PTVs. And so now if I make each ring 1 centimeter thick, different ways of doing this. You don't have to watch my exact steps. That's not the important thing. The important thing is that you get the same contours. I'll call this my Z PTV Opti Ring 1. So now I've got a 1 cm thick ring, 3 millimeters away from both PTVs. So again, we said 3 millimeters away from PTV 54, I'll put my maximum at 85% objective, but that's gonna be too sharp of a fall off for here. We just showed the math earlier, it needs to be 5 millimeters away. So again, we would do a crop structure from our our new ring that we created, parts going inside a PTV 60. It needs a little bit more margin for that fall off. And our math said it was 5 millimeters. We apply it and we just subtract a little bit more gap from our PTV 60. Okay, so this is, get rid of my temp. This is our new ring. It's a little bit further away from 54, according to 5% per millimeters, 3 millimeters away from here, but we limit it at 85% of the 54 prescription dose. Okay.
Awesome. Adam, there's also one question from Victor. Do you have any minimum dose requirement inside your PTVs?
Different doctors will want different. That's a good question too. Different doctors want different doses. We typically, in a lot of centers, will typically try and cover 98% of our volume, of our PTV volume, or in this case, 98% of our Z PTV Opti Max volume, 98% of that volume by 100% of the prescription dose. That's what we typically aim for. But different doctors might prefer different things, so that will be a discussion with your doctor. We also try to limit our 105% hotspots, maybe 10% of the volume or so. No harsh guideline, but we don't want too much, 5%. If you're getting too much, you can always add an extra field. I have found if you've got more degrees of freedom, you can typically optimize a little bit better. So sometimes you can do that. And the max doses are usually, the max doses within our Z PTV Opti Max are usually on the order of 8% for a max dose, depending on how complicated it is. This case was, again, quite complicated. It's a big tumor. Those big tumors are actually tough to optimize. I think we had a max dose of 13%. It's okay. So I'll quickly go to our optimization. I just want to show you a couple of things. So this plan has already started, just so I could jump into the optimization and show you a couple of things. Again, sort of forget the naming, but we'll just go through sort of what we're looking at. And so when you start your optimization in step 1, you'll see this in our planning tutorial, but you're going to want to bring the mean dose down. I'll show you this in a second. I'll get to that shortly. And I'll try to wrap this up in about 10 or 15 minutes. I apologize to everyone for going just slightly over. Okay, so it's already been optimized. Remember, we're not going to go do gross adjustments. We want to optimize our parotid, for example. So we're not going to do it in step 3 or step 4. So we'll go back. We'll go back again. And we can start optimizing in step 2, for example. So let's put on my parotid. Here it is. We got a mean dose of 27 in this case. And I'll show you this first, then I'll show you something else. So talking about lowering that mean dose, the doctor wanted it less than 24. I've already optimized it to where I've got 5% dose fall. Here's my 50% line. Really, really sharp. Here's my coverage. Really good. I've got 5 millimeters between my prescription and my 50% line, right? Going 50% decrease in dose at 10% per millimeter, that means 50% reduction in 5 millimeters, okay? That's what I have. So I can't get any further on my parotid, but I'm only at a mean of 27. My doctor said I could sacrifice. So I'll show you this quickly, how this works. The naming is a little messed up again, sorry, but you'll see the principle. Oops, I don't have my 52s on there. Okay, so here's my 52 max. So here I've got this little, the naming is wrong again, but I've got these little parotid segments. And so because my naming is wrong, I've forgotten which one is which. Apologies. So here's, okay. So part 2 is my full one. So let's say I want to decrease it 2 millimeters. So I'm fully optimizing my full PTV. That's everything here, including this whole section. And let's say I want to just optimize on this much and let it spare here. So what I would do, this weighting was 200, so I'll put 200 on both of these. And now I'll remove all the weighting on that one. We look at our parotid, it starts going down. Look at that. Pretty cool. So we can look at our parotid dose, went down to 26. Let's see if we can make it down, go down even more. So now let's forget this whole thing right here and we'll just remove it completely. And now let's see what our parotid dose does. going down even more. So it's helped it some, but that's sort of the idea behind how to do this. So if we want to push it a little bit more, now that this has gotten closer to here, maybe we'll say 2300, push it a little bit, goes down a little bit more, but that's sort of the idea. And make sure I've got, sorry, I didn't take this off. Hasn't gone down yet because I didn't remove these. I removed the wrong one. Apologies, everyone. That's why the parotid didn't go down. So now you can see these are those two little 2 millimeter sections of parotid. I just removed those so they can go down, but still keeping my coverage on the rest of it. And now if we look at our parotid, there we go. This is what I was expecting. We're at like 23 median, and it's almost achieved it. So we can go down further, say 2200. It's going to keep going down further, but the PTV that I want covered is still being covered. It's a cool thing. And we've got our parotid mean dose as low as we want. And I could add those sections back in and fully cover them and remove the dose again. So you can keep playing with those. You can cover, not cover, so forth. And I'll quickly show you that one idea of what you would do in step 3. So here now my 50% line is at the PTV surface because we've allowed it to miss coverage here. And so what you would do as you're progressing to step 3, for example, we just want to fine tune those MLC motions, but we don't want to sacrifice all of the gains that we've made on the major MLC motions. What we would do is, we're just going to let this get to step 3, but in all the steps, what we would do is we keep pushing each organ at risk one at a time. I'm only showing you one organ at risk right now at parotid, just to show the concept. So as soon as it gets to step 3.
Thank you so much, Adam.
Next, yeah.
Sorry, Mohammed has a question. Do you change the value of X and Y, something from 40 and 30 when you use the priority of 200? And if so, what value?
Yeah, so that's for...
I'm not sure.
I think that's for like IMRT, the smoothing factor, I think. Is that what he's talking about?
Correct.
Okay.
And
Yeah,
you're doing VMAT,
factor,
right?
Yep. So VMAT, we don't really have that smoothing factor. Maybe we do. I just never look at it. Apologies. The smoothing
I don't think we do, actually.
Okay, yeah, I don't think we do. But for IMRT, the smoothing factor, you can look at that. It can be a helpful tool to try and limit these little weird, really high hot spots and high dose or low dose. But hopefully just following these rules will prevent that anyway. But if you still find those at the end, you can increase those smoothing factors a little bit. It doesn't hurt. But hopefully if you follow these rules, no conflicting arguments will be okay.
Awesome. And Victor and Rola are talking about how their treatment planning system is different and they use Monaco. And maybe in the future, we can have some sessions for Monaco users. But I think our goal here is just to get the concept and be more familiar with the process per se. And of course, every treatment planning system is going to be different.
Yep, exactly, Sherry. So we are going to have treatment planning tutorials start to finish with Monaco and Eclipse. So we will show both. The idea of my presentation today, I'm not showing you start to finish a plan. I'm showing you concepts only. And so when I say like go back to step 2, that's an Eclipse, sure. But the idea would be maybe Monaco, you just sort of go back to the beginning. The idea is local minima and global minima. And the idea of these gross MLC motions versus fine-tuning MLC motions. So gross is at the beginning, fine-tuning is at the end. And different planning systems operate differently, but that's the idea. So you don't want to start with a dose distribution and then try to do a gross adjustment. If it's Monaco, go back to where you don't have these big gross MLC motions and then do your planning.
Awesome. Great point. And Jonathan asked a question. I'm not sure if he private messaged me, so I think it's a great question, so I'm going to read it to everyone. Does tissue density have any contribution to the performance of the optimization? I'm going to just copy and paste it in the chat so everyone can read it. Okay. So, sorry, I'm also trying to reward. But sorry, if you want to answer that.
Yeah, so
does tissue density contribute in any way to the performance and results of the optimization?
Not usually. So there, I think already has been a really nice lecture on tissue density and how that pertains to type B and type C algorithms. I won't go into all those details no matter how much I want to right now, but that it does have a big difference in terms of sort of clinical value. in terms of optimization, what you see is what you get. It won't have an issue on optimization. The only time that you might have a problem with optimizing on tissue density is if you have lung patients with some sort of extensive disease, or they've got other related disease like COPD, and they got really low density lung. We're talking minus 900 pounds per units, or even a little bit more. When you get that low lung density and you're optimizing on Acuros or Monte Carlo, your optimizer is going to struggle quite a bit. And your optimizer might show one thing, and then you calculate on the real plan with Acuros and Monte Carlo, and your shoulder is going to drop by 40%. So what we do in those cases, we'll do a PTV override of the low density tissue of the lung portion of the PTV. You can even expand it a little bit further, it doesn't matter. And we'll just override it to a more traditional lung density, say minus 700. And the idea is, if you remember from the Acuros Monte Carlo talk, is that really the difference, some centers will even override their entire PTV to water. And the difference in dose to the GTV is only about 2 or 3%. So it's not a big issue. So we'll just override to minus 700. That's going to have almost zero effect on the actual dose to the GTV and a moving ITV on the lung tumor. So that's the only scenario that I see that tissue density could have. Forgot to hit play. Sorry, y'all. It's waiting for it to go step 3. That's the only time that I could see it having issues in terms of being able to optimize.
Awesome. We do have some other questions, so maybe while that's being optimized, we can get to them. Amri is asking, why did you use 2 upper objectives for ZPTV with 2 different priorities, and the actual dose calculation is the same?
Yep. So I had 2 different. So if I look at some of my upper priorities, let's find a max one. So the name is incorrect according to our nomenclature, but you get the idea. So I've got a 98%. Sorry, I messed this up earlier and I didn't fix it properly. That was supposed to be like that when I accidentally erased all those constraints. Sorry, everyone. So I got this 98% at 0 dose. This is a dummy one. This has no weighting at all, but it's just showing this is where I want my curve to go. This is the coverage that we want in my clinic. All right, and then I've got the 100% at 1% higher than prescription. Then I've got 0% at 5% above prescription. And then I've got 0%. This is for Eclipse users only. And this 0% at the same 5250 is what I want 100%. It's just because I have normal tissue objective starting at 100%. It's only for Eclipse users only.
Yeah. Great, thank you.
Okay.
And Hassan is asking, the formula that you used quite a bit in this process, what was the MLC resolution?
MLC resolution doesn't matter. So you can have, I use the same formula for my high def MLC machine, which is 5mm MLCs. And I use that the same as
I think 0.25, right?
Yeah,
high def.
Yeah, high def at 0.25, and my Millennium 120, my interleads at 5mm. So, and even if I use a 1/7 MLC, which I know some machines still have across the board, I would use the same dose fall off. There's actually not a big difference in terms of how a machine can optimize in terms of MLC width. I think it's only important when you get down to stereotactic radiosurgery. For traditional VMAT, traditional IMRT, you won't see a big difference between 0.25, 5mm, and 1 centimeter. Okay, so quickly, can I show this real quickly? A concept in step 3. So we've gotten our parotid where we want it, 23 gray, max dose, mean dose. So what we want to do, we want to lock it in. And so we'll put a couple, either 2 or 3, like the bottom third of the dose, so 33% or less. And we're just going to lock this in place. So we're going to put a bigger weighting on, 300 for all of them. And notice when you optimize, you never touch your PTVs, you never touch your rings, you never touch your NTOs, and we will only optimize with mean objectives on our organs at risk of 150. And we don't need to go up higher than that. And I'll show you that in a second, what happens if you do, but that's all you do. Means of 150 for organs at risk. You can put some max doses on, and PTVs you leave at 200. So we'll lock this in at 300. and then we'll improve the shoulder just slightly. So you can go to my list. I'm only going to look at PTV 52 right now. So we'll put this at 300, 300. We'll do the PTV 50, the edges. That should be my Rind contour for my PTV 52. And we'll increase this. Here's my Rind contour. And so we've almost got coverage, but look, my parotid hasn't moved. Okay, let's go back. And let's pretend I don't put, I'm going to try and exaggerate this. Let's not lock this down. If I exaggerate it, it becomes much, much worse. But anyway, we'll just do it here. Let's I really get coverage of this thing. There it is. Okay, my parotid got a little bit worse. And so this is just a small example of what happens if you've really pushed it, and my parotid might be way down here, and I optimize. Sometimes you can lose all of that work in that gross alignment of MLCs just because I didn't lock my parotid down. So you want to lock it down. I'll show you one other thing. It's a helpful tool. So I'm going to do something I'm not supposed to do, but I'm just doing it for teaching purposes only. So let's put I'm going to bring this parotid way down. So don't do this. This is just for teaching purposes only. Let's bring it down even further. Okay. Okay. You can see in step 3 later on, it doesn't work very, very well anyway without those fine adjustments. So you can see where the optimizer is struggling in step 3 to make gross adjustments for my parotid. Okay. So, okay, let's say I've locked in my parotid here. And now I want to improve my PTV 52 coverage. Okay, I'm gonna try and do it quicker just for the sake of time. This is just demonstration only because I've sort of done some things I wouldn't do. I still can't get my PTV quite covered because my parotid has such high constraints. I'm trying to show you. Let's see if it will actually do it.
Adam, James is asking, you're using high percentage priorities, and
yeah, so in this
when he
case,
was
I'm trying to prove a point.
they suggested using low percentage too. Yeah.
Yep. So in this case, I'm just trying to show a quick point without, because we're running out of time, that the concept of trying to move an isodos, move your shoulder to this coverage point, but it's being held in place by this parotid objective. So if I can see it starting to go above the parotid objective, I can't quite get it. You can move these. These anchor constraints up, and it starts slowly moving this shoulder back up. Maybe not the best way of showing this because I optimized and I showed some things that I don't really want you to do on that side. But that's the idea, is to say if you've anchored your organs at risk in place and you can't quite get your PTV shoulder to get up to where you want it to go, you can relax those anchor constraints further up. Okay, so in terms of, I'll bring these back down to where they were. In terms of how much objective I put on, so this is a fake one. I would never do that with an organ at risk. Okay, so organs at risk only stay at 150. And then at this point, so just like I showed you before, when you get to the later stages, you should have PTVs at 200, organ at risk mean doses at 150, and then you would put in the 300s just to lock this in. So this should be a little bit higher. The 300s are just above it, just to lock it in. And then you would increase your PTV, and you shouldn't have to do much. So just like I showed before, if you go up to 300 on your constraints, then it should get your shoulder about to where we want it on all my PTV 52 objectives. And you can see that shoulder starting to go up and my organ at risk starting to be okay. And I think I've done some things to my MLCs in all this weird stuff I've done to it, because we saw earlier that my shoulder got to where it needed to be. So again, I've done some weird gross and minor MLC adjustments to prove some points, but you should only have to go to PTVs of about 300. You can go to 350 if you want, because I've already sort of messed up my gross alignment of PTVs slightly. And we're sort of to where we want to be, give or take. I just want to show the idea of using those. In terms of I'll show one more thing, and I think that's the last thing I'll show because I think it's really important. And thanks for everyone for staying on, those that could, just to see these last couple of points. So if we're at the very beginning of optimization, here's our original optimization objectives and my parotid. Okay, the original optimization. I got my MLCs are still stuck here. I'm gonna start over real quickly.
While you're doing that, Hannah from Morocco is asking, why aren't you using GUD, the biological optimization part?
Yep, we don't do it in my clinic, and so you can. This technique is just for DVHs only. It's not something you can't. You can implement this exact same technique while still using the GEUD objectives.
Thank you.
The idea is just to teach the technique.
And Anissa is asking about SRS plans, and do you have a special method that you use for your SRS plans, and how much dose follow-up do you usually get?
Yep, good question. So SRS plans, we'll have a whole course on SRS SBRT that we're working on. I'll be providing a different document for planning SRS SBRT, but typically you can have much sharper. And so without going into too much detail, I'll typically look for example, smaller single met lesions. I'll use my rings, I'll have a ring 3 millimeter away. I want 50% dose, maximum dose of 50%, 3 millimeters away. When I look at a SRS plan of a single met lesion, I'll use my measuring tool. I'll put my 50% isos line and I'll measure. If the planner doesn't have about 3 millimeters from PTV surface, 100% coverage to the 50% isos line, and then they can probably push it more. Of course, there are caveats to this in terms of the complexity, the size of the PTV, its adjacency to organs at risk, but that's a pretty good rule of thumb just to give you a sneak peek.
Awesome, great. I'm sure everybody's looking forward to that SRS SBRT planning session as well. One more quick question. How do you describe an overmodulated plan, and what's the implication of optimizing a plan multiple times to achieve a perfect plan?
Yeah, so another good question. So we don't want to over optimize a plan. If you follow this process, you will only have one optimization. If you have to do multiple optimization, you need to refine your skills and follow exactly this planning document. If you optimize it multiple times, you get a higher modulation factor. That means more MUs per dose, and that means more difficulty for your planning system to deliver. So if I look at plans that, say, a rapid plan model has done, or what other dosimetrists or physicists have done, they might have a modulation factor of 4 or 5 even on a really complicated head and neck plan. I look at my modulation factor is less than 3, and my organ at risk coverage is way better. My PTV, my organ at risk sparing is way better. My PTV coverage is a lot higher, but my modulation factor is much lower because I followed a systematic approach that the optimizer understands and separation of my PTVs.
Awesome, thank you.
And I'll show one more thing. I promise this will be the last thing that I'll show, just because I think it's really important. Yeah. In terms of optimizing mean doses, you'll do this for every organ at risk. I'll show you only parotid just to show you the example. So some optimizers aren't as good. The PTV shoulder will fall faster. My optimizer is actually pretty good at 15.6 in the clips, so the shoulder doesn't fall as rapidly. But you can also look at this other term. So you'll optimize mean dose, again at 150, and we'll do it one objective at a time. So I'll put in 150, I'll watch my PTV 52 shoulder. It hasn't dropped much. My parotid has gone down. I was able to achieve it pretty easily. It's almost reached my mean dose. I drop typically by about 4 gray at a time in my mean dose. So this has almost achieved it. So I'll drop another 4 gray. And I'll watch. So I'll watch my PTV shoulder. See, it dropped a little bit, but now it's starting to go back up, back where it was originally. It's dropping a little bit from where it was. My parotid is going down. It's getting closer and closer. And it's at about 1 gray to 1.5 gray. When you start seeing that it's getting not quite able Now I'll drop it a little, it's gotten about 1 gray away. I'll drop it a little bit more, let's say 3,200. When I see that it's not able to get within about 1.5 gray from my mean objective, it means that I probably pushed it enough. So it's still right around 1.5 gray. So it's probably been pushed enough. So I'll go ahead and go to the next step. And then the next step, I'll repeat this. Once it's about 1.5 gray away, it means it's probably been pushed enough. Then we'll go to the next step further on in the process. So that's just a key point. You do this for all of your organs at risk. You'll keep dropping by about 4 gray until you get about 1.5 gray away. That means you push it far enough. You always leave it at 150, targets at 200. Sorry, everyone, it took so long, but I hope this was helpful information for everybody.
Yeah, absolutely. There's also a couple more questions for those who have time.
Sure.
I know we went a little over. Mohammed is asking, can you put upper limits for body in VMAT or IMRT or not?
So I do not put any upper limits in body. If I'm optimizing in Eclipse, I will use my normal tissue objective. The normal tissue objective in Eclipse is smart. It knows not to have conflicting arguments between different dose levels of PTVs. There might be other optimization algorithms for other vendors that do the same thing. I just don't know. If I don't have a smart sort of total body optimization, I don't even need that in Eclipse. I could optimize without it, it's fine. Your rings are sufficient. So if I open up my rings, here they are, my rings here and here. So when I first start, they look sort of like this. When I finish, they would look sort of like this.
Awesome. Thank you.
I only
and do you use,
optimize.
sorry, go ahead.
No.
Do you use NTO in VMAT breast planning?
I do. So I optimize the exact same way for all sites, breast, head and neck. There are some extra things that you have to do with breast planning. Maybe we can have a tutorial on that.
Sure.
Hopefully they've been covered, but some extra little things for flash outside of the skin surface. But other than that, the same document works for every single site.
Awesome. Thank you. James is asking, for the start dose and end dose, what is the favorable choice for using these two variables?
Yep. So this is for Eclipse users only. This is what we use. For SRS, SBRT, it is different. Again, just different methods of optimizing different dose follow-up.
Awesome. And I think we do have one more question talking about highly modulated plans. Do you set a maximum MU number?
I do not. Again, because you'll find as you practice this process more, and it only takes you one iteration, and you have no conflicting arguments, it's easy for the optimizer, you're going to have really low modulation factors. And so you're not going to have that issue.
Awesome. And maybe this will be the last one. The distance from the target border, depending on the site, and what's the best choice criteria for that value?
Sorry, what was the question again?
Yeah, sorry, I need to, I guess, reword it. Is the distance from target border depending on the site, and what is the best choice criteria for that value?
So
I'm not sure.
The distance from the target border for dose follow-up is always according to these equations at the beginning. I think my computer's run out of memory. My document has disappeared, but it's at 5% per millimeter for big structures, or totally surrounding 10% per millimeter for small structures, or big structures that are a little bit further away or a little bit lower doses, 3% per millimeter.
Awesome. And yeah, thank you so much, Adam. This was great. And just a reminder for everyone, we do have a YouTube channel. I just shared the link with everyone in the chat, but it seems like some were not aware of it. It is really, really helpful to go back and rewatch some of these when needed. So make sure you also check that out. And yeah, if you need anything else, if you do not have access to the documents, please let us know. But thank you so much, Adam. This was absolutely wonderful. I personally learned a lot, and thank you so much. Yeah, everybody's also showing a lot of appreciation in the chat.
Okay.
So thank you so much. Of course. Thank you, everyone. Have a wonderful day.
I'll just say there are 2 RCC YouTube videos already out there on treatment planning for head and neck and pelvis, and we're going to create more in the coming sessions. So thank you.